I can, if you give me a second, I can pull this up. Let me do this. 809 case.
All right.
Yeah, let me just make sure everything is kosher here. All right. So let's see here. This is, oh, let me pull over the, this over here. Let me pull over the echo for this because this is pretty cool. And so this is a case that Sharon showed me the other day, and I had shown a case. I know Travis, or you guys probably all like this, where this patient had a type A dissection. What was interesting is you can see that there was a aortic dissection with the intima actually displacing into the left ventricle, forming this kind of windsock deformity sitting here. Can you guys see that?
Lovely, yeah.
And then, so we have some echo images where you can actually see this thing. Let me get the higher res ones, so the low res ones, where you can see this thing literally prolapsing back and forth across the valve. That's this one showing the associated AI. There's some really pretty ones, but I'll send those images along. Here it is. You can see this thing just prolapsing across the valve because of this aortic dissection. I had shown one, I think, a couple of years ago about one kind of tearing up and going and lodging in the left subclavian. A guy presenting with a cold arm, but this is pretty neat too. So I've not seen, this is only the second case of an aortic dissection I've seen with a dissection.
Yeah, yeah. Can you scroll through? That's lovely. Can you scroll through? Are you finished with that? Because I'd like you to scroll through.
I was just going fast. What do you want me to do?
Just scroll through the ascending aorta.
So there's, what's interesting is it came from here, right? Because you can see that here you have dissection flap, and then here you have nothing, and then you get back to dissection flap. So this intussuscepted portion came from this area where you don't see a second lumen. That makes any sense. So I think it tore off from here, came down, and then went into the ventricle. Because it wouldn't make sense to have it. It's not, you don't have two separate tears. The discontinuity in this ascending aorta is from that intussuscepted portion.
Right. So you've got a 360-degree tear.
Yeah, exactly.
Ascending. Yeah, and that reminds me of your other case, because I always show your other case with the one that intussuscepted into the subclavian, because it's the same thing.
Exactly. And this one went down. I mean, it's just fascinating.
Well, you have a circumferential tear at a certain point.
Yes.
And then
it pulls down like a dog.
Goes in one direction, antegrade, and the other one goes, in a sense, retrograde. And then the portion between, and then you end up with the empty aorta sign, in the sense that there's a portion of aorta where you don't see an intimomedial flap.
Is that an actual sign? I've never even heard of that, but.
Yeah, that's a description. So if you have a circumferential tear, the proximal tear is in the bottom, and some of it may go back into the ventricle in diastole. Yeah. And the other tear goes distally along the direction of blood flow. The space between the two flaps right there is the empty ascending aorta.
So you're saying, okay, so you're saying that here it is. So that's the balled up other portion then.
Yeah, the other portion goes in the direction of blood flow.
Right, because this has to be, this doesn't make this whole convoluted infolding of flap is very odd. So I'm assuming some of this, if you can see the arrows, following the arrows, is the other portion that came up and is flopping around in that direction.
Exactly. And then depending on the timing of the contrast image acquisition, at least with respect to the flap in the proximal ascending aorta, you may see it either going backwards through the valve or forwards through the valve. You see that with ultrasound, but what you see on the CT depends on when you acquire the images in part.
It would have been nice if we had a retrospectively gated study and you could see this thing, like you see it on echo going back and forth, but you could have potentially seen that throughout the cardiac phases.
Yes. So unless I'm mistaken, this is a really nice example of the empty aorta between
that's what I'm saying. This area here where you don't see a flap, that's where the
for a couple centimeters. Yeah.
I just didn't know it had a name. There we go. This is let me pull over another study real quick. This is something I've not seen either. So this is a guy who he had a IVC lipoma, and the IVC lipoma had been growing, and it wasn't really causing any symptoms, but it was growing. And you can see here, they're trying to snag this thing, and they tried for a while to get it, and they had trouble getting it, and they eventually just got around it and pulled on it, and unfortunately it didn't, here's a CT of it, it didn't stay together in one piece. So here it is before, see this large intracaval lipoma, and I guess they were kind of aggressive about moving it, and it broke apart, and needless to say, not the best study because the person was a little short of breath. I know people have seen fat emboli, but I don't know if people have seen fat emboli this fatty and this large. So this is actual big chunks of fat from the person's lipoma that embolized into the left PA, as well as I think it was primarily the left PA. And so this is a caval lipoma embolization due to attempted snagging of this thing interventionally.
Yeah, I think they're trying to grab it. That stock.
Yeah.
Hoping that way.
Oh yeah, here it is. And there's it went bilaterally. Here's in the lower lobe. So interesting.
Oh, very interesting.
The guy went to surgery and they had to pull out the big chunks of lipoma. Not funny, but just I've not seen that before. And this is a really cool case. You might have to kind of stick with me on this one a little bit. So this was a patient who came in because of abnormal chest X-ray and had these multiple pulmonary nodules, which were called, and something that was missed, which I can understand, was this abnormal thickening of the heart. It looks like normal myocardium. It doesn't look too abnormal here. They got an MRI for this, and I will try to quickly shoot through these. Let's take a look. But basically, the patient had what looked like, let's see if I can move this thing out of the way, just a thickened myocardium, and not really too impressive. So maybe this person has hypertrophic cardiomyopathy, and I'll show you the some of the delayeds. Let's do this real quick. And on the delay, you can see that, yeah, there is some enhancement. It's kind of hazy, mid-myocardial. Maybe this is hypertrophic cardiomyopathy. But if you go to the T2 weighted sequence, you can see that that's not normal. At HCM, you do not get abnormal T2 signal. It's basically just hypertrophy myocytes with some interstitial fibrosis. So there's something weird going on here. And I will save you guys the perfusion image, but here's the because the perfusion image is nice, it shows it. Here's the T1 post. And you can see that there's some hypoenhancement here. Now, the interesting thing, and I think this, I've talked to Travis and maybe some of you other guys before about this, we here get two different studies. We get a chest during arterial phase and the abdomen and pelvis during portal venous phase. Unfortunately, they come across as different studies, and honestly, I don't review their images. And I didn't read this, but I could have made this mistake as well. And you can see here on the portal venous phase from that original study that showed that hypertrophied myocardium on the same day, that there's this large infiltrating hypodense mass. And just to confirm that, here is a belly, that this is new. Here was a belly MRI from about 8 months before that showed that the heart was normal. So you have a large infiltrative mass in the myocardium in someone with, let me go back to someone with pulmonary nodules. You could think of other metastases, but really this infiltrative. And so this is literally a few months later, not maybe 2 months later. And now you can see multiple infiltrative cardiac masses. This one's actually popping through into the pericardium. You're seeing nodes everywhere. And these pulmonary nodules that have grown. And this was actually B-cell lymphoma. So it's a case, a nice case. And I've heard of case reports of B-cell lymphoma mimicking hypertrophic cardiomyopathy. In this case, it kind of does, except for the, I mean, there are other things to tell you, but the morphology and the delayed enhancement kind of do look like it, but all the other stuff is wrong. So that's just another case. But
Wow.
that's what I got.
All right. Cool. Okay, who is next?
I've got some.
All right.
Okay, do you see my screen?
Yep.
Start with this one. This is an interesting case, and I'm sure Seth will like this because we've shown some of these before, but this is a variant of this type of injury. So this is a young guy that I came across this radiograph a couple weekends ago. He was apparently trying to cross a highway and got hit by a car. His lower extremities were the most severely injured, but you can see on this radiograph here that especially in the setting of trauma, we have several abnormalities in the mediastinum. Notice that the aortic knob where the aortic arch is not well seen, and you lose the AP window. It looks like you've even got maybe a little hematoma along the descending aorta, and then certainly there's rightward deviation of the trachea.
Yes.
All findings that would suggest that this patient could have acute traumatic aortic injury. And he had a CT done, and this was just the trauma pan scan. And we do in fact see that he has a mediastinal hematoma. But what's interesting about this is the location of the aortic injury. And the aortic injury is right here. So it's above the sinotubular junction a few centimeters, and it's in the ascending aorta, which I remember Seth showing the case at the root. Certainly we think about the root, the isthmus, and even the diaphragm as the common locations, but I've never seen one in the mid ascending aorta like this, or not really mid, but it's above the sinotubular junction in the tubular aorta. You can see on the coronal that clearly this is the focal area of traumatic aortic injury, and it involves more than 180 degrees of the aortic wall. But I was holding off on showing this because he had several other injuries that they dealt with first, and they did finally take him to surgery after about a week. And not surprising, they found they said it's nearly circumferential, about 2 centimeters above the commissures, above the sinotubular junction. So it's acute traumatic aortic injury of the tubular ascending aorta in a very unusual location.
They waited a week well, you must have some really I mean, that's crazy.
Yeah, they did a follow-up CT a couple days later. It was unchanged, and there was some question at the outside hospital. One of the surgeons looked at it and thought maybe there's some motion there, and we were like, no, that's nonsense. This is clearly traumatic aortic injury. It's just in an unusual location.
Wow.
And this is one of those ones, probably if they'd let it go, if he lived that long, you never know. Maybe this would have healed and calcified, and you just see a chronic calcified traumatic aortic injury in the future. But this guy was obviously lucky in this sense, not other parts of his body. I think on the CT, now that you mention it, Seth, I think he had pelvic fractures, he had a bladder rupture, he had a bunch of lower extremity injuries as well. So that's what they attended to first. Then we had a run of interesting cases. This is one, also an interesting case, and I've got a theory here. This was as you can see, 83-year-old man. At this time he came in, or when he had the CT, he was intubated. So he was in the hospital and had apparently a witnessed arrest. and he underwent resuscitation, was resuscitated successfully, and then underwent this CT. And you'll see that he has some mediastinal hematoma, but he has a large volume of high attenuation pericardial fluid. And so this is, and he's had a prior aortic valve replacement, and so he's anticoagulated. So of course this is hemopericardium. And as I always tell our residents and our fellows, you know, that hemopericardium should scare you like subarachnoid hemorrhage does. And this was actually, this was overnight, and it was, they noticed the hemopericardium, but unfortunately what they didn't realize was that basically you have this volcano of contrast coming out of the right ventricle, and it's near the RV outflow tract here, and you can see the hole in the RV. And so this was after CPR was done. And so this was, you know, this is definitely, I think, a rupture of the RV due to the CPR. Even though you don't really see any rib fractures, I talked to the team afterwards. You know, he's got a small little, maybe a little fracture here, and I looked for some discontinuity of even the costal cartilage in this area. But the clinical team that resuscitated him said that his sternum just felt like it was just like a flail chest. That, I mean, they definitely broke a lot of his ribs there. But what's interesting too on this, and I think this is where my theory comes into play, you can see there's a little decreased attenuation, decreased enhancement of the LV, and they did an abdomen and pelvis, and you can see that it certainly looks like he's got either subendocardial ischemia or probably an infarct. And so I think what happened was that this guy probably had an infarct, which is what led to the arrest, which is what led to him needing the CPR. He was DNR DNI, so they didn't do surgery on him anyway. But this is the first time I've seen an RV rupture from CPR. It's certainly a well-known complication when you're mashing on the heart. But the other thing I'll include is the timing bolus series, and you can see that when you inject the contrast, you'll see that the contrast goes into the RV, and then immediately you can see it coming out into the pericardial space there. So I always think these timing series are interesting, some of the clues that you can see. So
Very impressive. My goodness.
Yeah. So at least that's my theory of that he probably had an infarct, which led to the resuscitation. And the timeline of his troponins being elevated and such fits with that as well. Let's see, what do I want to show next? I'm going to show this one just because we're on the aorta theme here and the radiograph theme. And this is a patient who came in, you can see there's atherosclerotic calcification, and came in, arrested, is intubated, and this is the first chest radiograph. And I think in this case, we have other findings of some sort of mediastinal hematoma or aortic pathology. This is not a trauma, but you can see the calcification, but we really obscure the aortic arch, and then you see what I think is a pretty impressive example of an apical cap. So this hematoma traveling along the left subclavian artery and along the apex of the lung. You really lose the left pulmonary artery as well. Now this is one where, you know, the way that this was handled on the scanner, they actually did this as a PE study. And you'll see, of course, there's, you know, this is no surprise going to be an aortic pathology. And you can see that she has a type A dissection, a large ascending aneurysm. And you can see the fenestration here with contrast filling this false lumen, and then, you know, mediastinal hematoma, hemothorax on the left. But what I don't exactly know why it happened like this, but I think the surgeons were involved, and so they immediately wanted to do a dissection protocol after the PE protocol. You can see the timing here, which is, you know, not really necessary in this case. But this is interesting, and that my colleague Kim Kaliana showed this to me. So this is actually non-contrast, and you can just see there's contrast on board from the PE study, and you can see how the contrast has spilled out into the pleural space, and then also into the mediastinum, I think, and along the left, above the left lung, and also into the pericardium. So you have contrast that's mixing in there, and then they did a follow-up just with contrast, you know, gave contrast again, just showing the same thing. But this patient, you know, she passed away shortly after this exam, but it's just an interesting time sequence of seeing contrast in different spaces at different times. And I think, Howard, you'll agree there's a little bit of shared sheath hematoma as well. In this case, along the pulmonary arteries. No surprise.
Sure, looks. Yeah.
Yeah, and I think, and then just a bonus, I think she had free silicone injection into her breast at some point in the past. So,
What was the time delay between the two studies?
oh, like 10 minutes. No,
Oh.
15, it looks like 15 minutes. I mean, I wasn't here. I have no idea why she was still on the scanner. I mean, I don't think there would ever be a reason to keep them on the scanner other than if they're not going to intervene on it anyway, but.
Yeah.
So, Jeff, I'll show one more if that's okay.
Okay, sounds good.
I'm going to change gears here, completely change gears, just because this has been putting together a solitary pulmonary nodule talk, and I came across this case. So this is a patient who has interstitial lung disease, and this was back in 2014. And you can see that they have this nodule here, and on the axial images, it looks a little bit more, round, maybe even a little lobulated. And of course, in somebody with interstitial lung disease, especially UIP or IPF, you worry about patient developing cancer. And this was, I think, the first study they had. But you'll see that this is along the fissure, and I think even you can make the argument on the coronal view that it looks a little bit more triangular. And certainly, you could argue that this is a periphyseal nodule, or more specifically an intrapulmonary lymph node, given this appearance, even though it's a little on the large side. But given his risk factors and stuff, they actually went to biopsy, and you can see the biopsy. This was confirmed as an intrapulmonary lymph node. So it's the one pathologically proven case I have of a large intrapulmonary lymph node. And I'd read this study last year as a follow-up, and you can see that it's still there and similar in size. But going through, the data, the one paper from the Dutch group in radiology looking at these intrapulmonary lymph nodes or periphyseal nodules and showing that none of them turned out to be cancer, after a 5.5-year follow-up. And there was a more recent study in 2018 from a different group, applying the same concepts of these triangular periphyseal nodules almost certainly being benign intrapulmonary lymph nodes. I think this is a good example of one that's a little on the large side, but they can still get this large. So I will stop there, Jeff.
All right, thanks, Travis. Okay, David or Howard?
Yeah, I've got a couple of cases I can show. I'll show two nice ones, and then.
Okay.
Okay. Let me bring this up here like that and start with this one. Okay, this is interesting from several points of view. Let me just get this one to show better. First off, it's a very nice example, particularly for trainees, of imaging findings of obstructive left upper lobe atelectasis. So let me bring up the two views. All the findings one would like to teach: the opacity in the left hilum. It's not a normal hilum. The hilum is elevated. There's ill-defined opacity. The diaphragm is up. On the lateral projection, one can see the anteriorly displaced major fissure with opacity anterior to it, because it's a little bit elevated. So really nice findings of first obstructive left upper lobe atelectasis. Now I'm going to show you something that's really subtle here, but I'm going to show you the CT in a moment that makes it quite interesting. So if you look up here as I zoom up, and I hope you can see this, but there's an interface here, about here, to there, like that, that is sharp, relatively sharp. But again, here is the interface that one can perceive, and it's kind of subtle, but it's like that. So now I'm going to show you the CT that goes along with this. And thanks to Leif for showing me this case, because it turns out to be rather interesting. So here we begin consistent with elect right here. See, I'll make it up, that anterior to the lung is pleural air, or looks like a little pneumothorax. It is a little bit of gas in the pleural space. So when I saw that, I said, that's probably a really nice example of the pneumothorax ex vacuo sign of Woodring, or Woodring et al. Then, of course, having said that, I have to go and find that article from Woodring et al. And this is the one. So this goes back to 1996. Now, the images, of course, on this PDF are not very great, but I'll just mag up this concept of pneumothorax ex vacuo in the context of lobar collapse. So the idea being there's an increase in negative pressure as the lobe wants to expand, but it can't, and gas is drawn into the pleural space. I wonder if it's nitrogen. But the bottom line is that this little collection of pleural gas does not want a chest tube, and it'll go away when the atelectatic lung re-expands. So a really nice example of the pneumothorax ex vacuo sign in the context of lobar atelectasis right there. So that's the first interesting part. So let's get to the second interesting part, which is the obstructing lesion itself. So we look at that and we say, yep, here's where left upper lobe bronchus is. Can't really see the lingula, but there's abnormal opacity in here. There's the obstructing lesion. What is the obstructing lesion? So let's go to think about endobronchial things. And in the context of endobronchial neoplasms that are benign, because this one is benign, one would think of, let me just snag this one up. Typically think of mesenchymal tumors of different kinds, including the schwannomas. Here we have the squamous cell lesions, and here we have the lesions that are other than that. And now let me show you the nice images I have from bronchoscopy. So here we have the lesion. You can read that over there. It really seems to be coming up the lingula and popping in. And you can see before and after. So they biopsied that, and then they froze it, and they burnt it, and they took it out. And here's the bronchus afterwards, and the lingular bronchus is nice and open afterwards. And here is the pathology. So this one is basically, here's the endobronchial lesion from the pathologist. And it's basically a lesion that just consists of glands and dilated ducts filled with mucin. He didn't want to call it an adenoma. I'm not quite sure why, but it's a benign lesion, and it's in the spectrum, I think, of mucinous gland adenoma. But he just described it as dilatation of glandular ducts. So that's the responsible lesion. So benign, they took care of it with the bronchoscope. So nice pathology and a nice example of left upper lobe collapse and pneumothorax ex vacuo. David, you like that one?
I love it. It's beautiful. So this is the most convincing ex vacuo that I've ever seen. It gets promoted a lot, but it's not very convincing. This one is convincing, and it's that sorry, that upper lobe distribution right outside the collapsed lobe, just hugging that one area.
Yeah, it's curious, isn't it?
Thank you. Question just regarding nomenclature here, because I was always taught that ex vacuo and pneumothorax would occur in a setting like this, but I know others use it interchangeably with trapped lung and say that, like, after you tap an effusion in a patient that has a, pleural thickening, that's another cause or another instance where you can use the term trapped lung. But I don't know if I agree with that. What do you guys think?
Either trapped lung or ex vacuo.
Can you use those interchangeably?
Used in that context. I have heard it used in that context too.
I think that confuses the concept. I don't think that's the same mechanism at all as what Woodring described and what Howard is showing here. So I don't think that's appropriate. The problem in those conditions of trapped lung is that the lung can't re-expand, and when you take away the liquid, you're going to leave behind gas. It's not as if it formed because the lung collapsed and sucked the gas there. It's because you introduced it when you drained the effusion, and it's not going to go away because unless that space refills with liquid, there's going to be gas there. I think that the mechanism is different. I don't think it's appropriate to use ex vacuo for that as well.
Okay, good. I agree.
Yeah, it's a different thing. But that I agree with, yeah. Okay, let me show you number 1. Let me see what this one is. Okay, just give me a second. Okay, here is another case which is really interesting. So I'm intentionally showing you 4 radiographs, and I'm going to show you the timing here. So 2011, 12, there was some in between, but I'm going to show you representative images from earlier this year. And then I'm going to tell you that there are some findings on these that are subtle, but they're all the same. And they're pretty much present to one degree on all of them, but not appreciated, not reported. So I'm going to just bring them up in turn. So take a look at first this one. And this is the one from 2012. I'll show you 2011. See if you see anything interesting here. And just concentrate on the mediastinum. And there's a subtle finding there. Let me go back to 2011 and give you a look at that. Subtle finding. And I'll show it to you in a moment. And now I'm going to go to this one. And the same finding is there, but there's an additional finding. And then I'm going to give you the next one, in which one of the findings is still there. So I'm going to go back now and just quickly show you the finding on each one of them. So the finding here is up here, where next to the trachea, there's air. Next one, back in this time, same thing right up here, next to the trachea, there's an air-containing structure right here. And then on this one, in addition to air right here, there's also this, which is this abnormal interface in the azigoesophageal recess, like that. So air in the lumen of esophagus, and then this is also there. So all of these examinations show, over many years, a dilated esophagus, dilated with air, and or in a case like that, dilated with ingested food and fluid. And now I'm going to close some of these guys and show you the CT. One was done in 2012, which I wish had been reported a little bit better. But notice that in 2012, there's no PE, but there's a lot of basal lung disease. Now, because of motion and sharpness, that doesn't show up really well. Notice there's a lap band, but you can see the esophagus that's distended. But let me show you the CT more recently, which is much easier to see the findings, along with the esophageal pathology, esophageal dilatation. And just look at the extent of abnormality in the lungs from top to bottom. Multiple opacities, consolidated ground glass, about bronchovascular bundles for sure. And then just for those trainees that are there, I'm going to just quickly show you a couple examples of, if I can find it real quickly, some really nice bronchiolar opacities or tree in bud, so that there's airway abnormality down here in the right lower lobe. In areas like this, so for example, here's a little bronchiolar opacity there, and here's another one there. So I read this out as bronchopulmonary aspiration for sure. And what was interesting was when I went back to the clinical record, I'm going to show you notes here going back to 2011. So look at that note. 2012, look at that note. 2013, look at that note. And there were other ones too. Finally, there's a note from 2014, and you can see that history right there. That goes along with everything else. And you can see for years she was just followed. And eventually here, more recently, when my report was at its strongest, I put this comment there. Finally, they're going to decide this person has bronchopulmonary aspiration that's responsible for years worth of morbidity. And it's about time they need to fix this. So I thought I'd show you that case. It took a long time to, and I'm not sure why, to really diagnose this person with their primary problem.
So Howard, the CT scan interpretation didn't mention the abnormal esophagus?
On the remote CT from 2012, I don't think it did. Let's see how abnormal that is in 2012. You know, it's not as distended there. There's a bit of air. There's a bit of fluid there. I don't think it mentioned it particularly. I can't remember for sure about this.
Okay.
But it certainly wasn't mentioned on the radiographs. And, you know, people just, I think, quite didn't really pick up on this and put it all together. You know, 1 + 1 = 2. It just took years and years for, and she saw so many different physicians. I think that too many people were involved. They didn't just get the whole picture. Huh? They just
Mhm.
didn't get the whole picture for a long time, as I'm showing you here.
Wow.
So her lap band is too tight, and that one gastro EGD really showed pretty much everything. And I wonder if people didn't really read this carefully enough, because she was followed for years after this. So I thought, interesting.
So Howard, do you think this is ordinary achalasia, or do you think this is lap band being too tight?
I think it's maybe lap band that's too tight. That's my assumption.
Got it.
That's my assumption. And they've been just treating her with things that are not going to really help her. Just giving her things for heartburn is not going to help her. This is a persistent and substantial aspiration syndrome over many years. Yeah. Okay, those are my cases, Jeff.
All righty, thank you. David, you got some cases?
I have some cases here. So are people viewing a radiograph?
Yes.
There are these things hugging the upper mediastinum here, and they go nicely above the clavicle, so they must be posterior. And it turns out there are these big posterior masses associated with both sides of the spine. And then there are these vague things that you see here along the edges, and on lateral view, you can see there's a bunch of stuff behind the sternum here. So we've got all of this sort of soft tissue stuff that seems to be around the edges of the lung. And this is from a PET CT. We don't have formal CT scans. We just have the CT for as part of the PET CT. And you can see there are these big paraspinal masses here. And then anteriorly, chest wall masses here, indenting lung on both sides. So when I first saw this, I thought this looks like extramedullary hematopoiesis. With all these lumps around here. I like the paraspinal location. Upper T-spine is good. One good location for extramedullary hematopoiesis. It turns out that this is extraosseous myeloma. This person has myeloma in bones, but also has these huge extraosseous components, and they're not clearly associated with destroyed bone. So I mean, the bone's not destroyed here. It doesn't look like, for instance, metastatic renal cancer with bone destruction and then tumor surrounding the bone. It's probably leaked out of these bones, but not with really broken cortex, maybe porous cortex or something. But we have all this extraosseous myeloma. This is a dramatic case, just in terms of the bulkiness of it. And as part of the PET scan, there was modest uptake in this stuff, but it's not bright. So, the glucose does get taken up in this, but not as if there's for instance, metastatic renal cancer again. It's just not that bright on the PET part of the scan. Okay, so extraosseous myeloma or plasmacytomas. And then here's a man in his, I think, around 50, who moved to this area recently, has been known to have HIV for a long time, was on some heart. He's tangled with a shotgun. This looks a fairly tight distribution here, implying that he was close to the muzzle here, and it's a nice tight configuration there. His lungs look pretty clear though. But on CT, this man with HIV has all of these very discrete, punched out cysts in his lungs. And a lot of them are in the bases down here. And this isn't really the distribution that I've seen with residual cysts after people, for instance, have had pneumocystis pneumonia, which tend to be upper lung and often along the periphery. So if these were hugging the periphery and there were upper lung concentration, I think this might be the residuum of pneumocystis, and that still could be the case. The man says, and the history we have says he's had multiple infections, but it didn't list what they were. So presumably people in other parts of the country we knew more about him, had a better list of his infections. This one is on the edge here, so perhaps these cysts are left over from pneumocystis pneumonia. But the intriguing concept, and what I would love this to be, and this I think would please Howard as well, is could this be the LIP that goes with HIV? And they're very clean cysts and stuff like that. So, you know, perhaps that's the case. I would love this to be LIP because I don't have any cases of LIP in the setting of HIV. It's supposed to be more in children, but you know, this would be lovely if this were an adult case. Can anybody help me with the differential diagnosis of cysts? I think Travis, that there was a lot of HIV in the old days, at least in San Francisco. So you might have a lot of experience with HIV. Have you seen LIP in the setting of HIV?
I can't remember seeing it. I guess the only other thing would be post-infectious.
Yeah, that would, and particularly with pneumocystis.
Yeah.
Would leave behind some nice cysts. Okay, so I'm hoping it's HIV, and I don't think we'll ever get an answer, but when this case came up, that was the first thing that popped to mind, but maybe that's just desire for wish fulfillment.
Well, David, they do have the nice perivascular distribution you see with LIP, so it looks good for it.
Okay, thank you, Jeff.
Yep,
You're my
that's
friend for
still.
life. Do you like it, Howard? Would you go with LIP?
Yeah.
Okay.
Yeah, you know, does he have a lymphoproliferative disorder? Did he ever have a lymphoproliferative disorder? I presume by virtue of history, if he had had a lymphoma treated, we would have known that, right?
I would think that would have gotten mentioned, right?
But I've got one patient with cysts in the lung, and his lymphoma was a skin lymphoma on his scalp, and he had been treated by a dermatologist, and that history could have been missed. So when people say lymphoma, we shouldn't always think about just the usual gross lymphoma with lymph nodes and whatnot. Sometimes the lymphoma is more modest, like a skin lymphoma. But that's something to think of in the HIV population, is whether he had a lymphoma of some kind. That's what I would think of too, yeah.
Okay. Okay, guys, by committee, it's definitely LIP. Okay. And then this person has basal predominant emphysema, is a cigarette smoker, but was also a Ritalin user. So when I saw this, I thought alpha-1 or Ritalin. And on CT, pretty modest upper lung emphysema, and then really striking basal emphysema here on both sides. And in the interesting thing about alpha-1 antitrypsin deficiency and Ritalin as well is that when they get this really confluent, fairly uniform emphysema, it becomes harder to recognize it as emphysema because you don't have the transitions between the holes in the lung and more normal parenchyma. When it's really wall to wall, where it goes all the way out to the edge of the lobules, you just have the sea of blackness and spread out vessels. So it's really the vascular spreading here that's the clue you're left with, that there's emphysema here. This lung is expanded, but you don't really see discrete holes anymore because of the confluence. So when the emphysema goes all the way out to the edges of the lobules, it becomes harder to recognize in some ways as emphysema. So this was Ritalin emphysema just by history. So he's a cigarette smoker. I think he'd been tested for alpha-1 antitrypsin. That was not abnormal, and he did have a history of Ritalin abuse.
So he injected the Ritalin?
Yeah, right. It's injected Ritalin, and he's got maybe a little flattening of the diaphragm here on lateral view, and maybe a little pulmonary hypertension here. Okay, so
Very nice imaging findings here.
Okay, and then this fellow has an interesting work history. I don't have a chest radiograph on him, but he's got several. These are all outside CT scans. So lowish lung volume here. He is obese, that's part of it, but he also has a lot of lung disease. This is chronic lung disease. It's been there for years. And this is what it looks like on cross section. It's mostly peribronchial upper lung concentration. It does go out to the periphery somewhat, but it's really more peribronchial. Most of it's an upper lung does have a peribronchial component down here in the lower lobe that goes out to the edges, but it really doesn't seem to be cleaving to the periphery. It's really more peribronchial. And the work history in this fellow is that he works in a corrugated cardboard manufacturing plant. And he had his symptoms were worse. He was away from work when he went back to work. And that was one of the things that indicated he probably had hypersensitivity to something in that environment. I haven't had a chance to read about the sort of exposure that people get when they're exposed to cardboard manufacture like this. But I think one of the things that can happen, and was true in him, is that they found he was sensitive to a penicillium species, and that probably in that, with all that, you know, moldy paper product stuff like that, it may be fungus that's at least partly responsible for the hypersensitivity. He did have a biopsy, and he had peribronchiolar fibrosis. It was considered to be consistent with a chronic hypersensitivity. So the occupational medicine physician made a note that the impressive thing to him was how the symptoms related to his presence in the workplace versus being away from the workplace. So that's sort of cinched it. So I don't think he's working in the cardboard manufacturing plant anymore. So let's see what it looks like here on coronal. That ought to help bring out this upper lung peribronchial distribution. Yeah, indeed. So chronic hypersensitivity pneumonitis in the setting of corrugated cardboard manufacturing.
So, David, there is an entity called wood pulp worker's lung, which is a form of HP. So he's exposed to pulp, but it's from one of the fungi that exists in the wood.
Yeah. Right. So I'll do some more, and if I find something relevant specifically to corrugated cardboard manufacture, I'll post it along with this case. Okay.
All right. Let's see here.
Thank you.
Let's see. Okay. So we'll start with this first case. Hold on here. So I'm going to be kind of along the vascular theme for a little bit, continuing along. So this was an incidental finding that was pointed out to me, just kind of a cute picture here, but this is something we've talked about and seen on here. So you can see this is a contrast-enhanced CT. There's some gas and stuff in the chest wall, but you see here's the left brachiocephalic vein. It's a fairly normal-sized vein. Sometimes it gets nut-crackered between the arch vessels and a sternum, especially if you have a hypertrophied articulation. You can see we see that here, sort of narrowed there. But then there's this other vessel that's running south, and so we typically see that vertically oriented vein as either a left SVC or as, if it's flowing northwards, it's anomalous pulmonary venous drainage. But in this case, that vessel actually dips under the aorta to enter the superior vena cava. So this is a circumaortic left brachiocephalic vein. More often you just see a subaortic one that can be seen in isolation or associated with sometimes tetralogy of Fallot, but this one is the normal pathway we see, in this presumed embryologic remnant stays open. Now, I had some older CTs, and this had been there over multiple scans, but I wonder if that pathway was sort of always there, or if this sort of stenosis over time recruited this pathway as a means of draining that brachiocephalic vein.
That's interesting.
Yeah, so just kind of a cute finding, and you can imagine it can have implications for PICC placement or other central venous catheter placement, and may take an odd-looking course, but it's a good-sized vessel there, so a small catheter would pose no problem, but it would have a very odd orientation. Okay.
Yeah, very nice.
And then this is a companion case, and let me go and pull it up and then share the images. So this patient was presenting, I'm going to show the images, presenting with some neurologic symptoms, and let me just do the CT here. And so they did an echocardiogram and saw some abnormalities and proceeded to do a bubble test. And when they injected the left upper extremity, the bubble test was normal, but when they injected the right upper extremity, the patient had a TIA promptly thereafter, and it subsided. So the CT was done to sort of look at this anatomy. And so along the discussion of the last case, In this particular case, we don't really see a brachiocephalic vein. There's some thymic veins. Rather, we have duplicated superior vena cavae. And you can see this is a left injection. And we can follow the contrast down. There's a large intercostal vein coming in. And it continues as the great cardiac vein joins up and drains into the coronary sinus and into the right atrium. So a typical left SVC. But what's unusual about this case is we see cases where when there's a duplicated SVC that the bridging midline vein is usually absent, and that is indeed the case. But the fact with the history tells you that something's not right on this right side. And what we can see is there's the pulmonary artery, there's the SVC. But as we come down, we start seeing this vein right here. So we have a superior pulmonary vein that drains into this SVC. And then another branch coming from the anterior portion. And then that connects directly into the left atrium. So there's this anomalous venous drainage is frequently associated with a sinus venosus type ASD, but in this patient there was none. So it's an anomalous drainage to the SVC without the atrial septal defect, but there's still a shunt. Of course, it's going to be a left to right shunt. No, I'm sorry. It's going to be systemic. Sorry, right to left shunt backwards there. So this is why he was having the neurologic symptoms. Little clots and whatnot were flowing up to the brain. Now I have a cardiac MR was done, and I won't show all of it, but if I can find the perfusion image here, yeah, you can see that on the MRA. So here's a left injection. And we can see the left SVC draining into the great cardiac vein, into the coronary sinus, into the right atrium. And then this vein, there's the pulmonary artery, and we can catch the vein coming in early. There goes into the other side. So I have a bunch of images there. You can play around with them. But this is just an unusual one that had both. And the MR confirmed that there was no sinus venosus type ASD.
That right-sided SVC does not even attach to the right atrium, right? It just dumps right into the left
right atrium. To the left atrium. Yeah, it doesn't touch the right atrium. So the right atrium is filled by the left SVC and the inferior vena cava.
So that's, Jeff, I showed one, and except our patient had
down there, Travis.
We lost.
So I showed one almost identical to this 6 months ago, I think. And did your patient have an echo with a bubble study, or was it just TIAs that they were having?
They did an echo, and they did a bubble study. When they injected the left, it just showed, it didn't show any problems. But when they injected the right, he had a TIA.
Yeah, okay. That's exactly how my patient presented. He had a TIA when they injected the right upper extremity.
Yeah. So
straight into that.
They're like crisscross SVCs.
Yeah, it's really weird.
So Jeff, how many anomalies is this? Does this meet Kanne criteria for multiple anomalies, or is this just one anomaly?
Well, the left SVC I consider a normal variant, but the right is anomaly. I looked for airway anomalies and did not find any.
Okay.
So I don't think it's the rule, but
I mean, I wonder. I mean, guessing the vast majority of the blood must go through the left. A, the left atrium is higher pressure, and B, the right atrium is lower pressure, but also just given the fact that the heart is not enlarged in any way, given this long-standing shunt, I'm guessing, 80-90% probably goes through that left side versus that right side. That's interesting.
Yeah, and if you look at it, I mean, there's some size discrepancy. Right. Left is bigger.
Yeah. Right cave is so small, it probably doesn't have a lot of volume.
It's just a pressure difference between the left atrium and right atrium. It's much easier to go to the right.
Yeah. So, in talking with one of my colleagues who was at the cardiology conference, the plan, I think, is to disconnect the right SVC from the left atrium and connect it to the left SVC. So route the blood in the correct location. Okay. And then the last case is not a vascular case. Let me pull it up here and get them in right order, and I'll show them. So this is a patient with metastatic melanoma, and I'll get the images up in a second, who's being treated with nivolumab. And I know I've seen some nivolumab cases before, and then I got to show you this image. All right, there we go. And was having, I had found a bunch of scans going back, but this was a few months ago and was presenting with this mass-like area in the middle lobe and then another mass-like area of consolidated lung in the right lower lobe. And you can see there are air bronchograms, and there's a little bit here in the left lower lobe. And I think one of these scans was done somewhere else, and this was called infection, and no effusion or anything like that. But when I see these discrete mass-like areas of consolidation, especially when there's little subpleural sparing, and I always think you can X-Acto knife these out. One of the things I also think about is an organizing pneumonia. And of course, anytime I see any of these funny named drugs, these ABs or whatever, I always think about organizing lung injury. So this patient, this was eventually called a drug toxicity, and the drug was stopped. The patient was started on high-dose steroids. And so that was the initial, one of the scans where it was the most compelling. This was about 2.5, 3 weeks later. I'm just going to put them up side by side here. And what you can see with the steroids, this dense area of consolidation.
Only seeing one.
Oh yeah, I got to trick it I don't know how to make it show both. I don't know how to do that with this version. Okay, well, anyway, you can see these are kind of evolving. This one became more expansile, and you see that they're breaking up a little bit along the edges, but still there was a lot of consolidation, maybe some central clearing developing. So that was, and then we're going to jump ahead not even 3 weeks later, and at this point you're starting to get some, atoll reverse halo appearance. So the lower lobe stuff started to clear up eventually. Same thing with this middle lobe mass. It got a lot smaller. Notice the airways are maybe a little juicy, and you can see that in organizing pneumonia, and it's not true bronchiectasis. But what was interesting is, so the patient had tapered the steroids at that point, and then this was the scan I came across. So this is about 2 months after the last one, and all of a sudden these new nodules appeared. And you notice many of them morphologically very similar but smaller. You could X-Acto knife them out. They have, they're in the periphery, predominantly along the airways, but very much a good look for organizing pneumonia. And so in my conversation with the oncologist, there was some confusion because they had treated this drug reaction. They had not restarted the drug. You can see the lower lobes were continuing to clear up, sort of cleared from the center out, which is what we see with organizing injury. So when I asked, I found out that the steroids, they had gotten down to a pretty low dose. So I suspect this is one of these patients, and I don't know what the half-life of nivolumab is, but I can't imagine it's 2.5 months worth of drug, but that this is one of these patients that the steroids may have been tapered too rapidly, or they just, they require a longer suppression. And that's been my experience with these organizing injuries, is that often they need about 6 months of therapy and pretty high dose. I think she was like on 1 milligram per kilogram, which is a pretty high dose of steroids, but they either get tapered too quickly or they don't stand them long enough. So back on steroids again and started to clinically feel better. We haven't imaged again because it's only been about a week, but probably get another follow-up on this. But I'm seeing these all the time now in routine oncology follow-ups where they have little or no symptoms, but also patients coming into our emergency department, coming in with cough, shortness of breath, and the radiographs are always worrisome for an infection, or in this case metastases, especially since the drug had been stopped. I think with these, we're seeing more and more with the immunotherapy, a lot more than I did with cytotoxic chemotherapy.
The same thing happens, Jeff, with people with eosinophilic pneumonias. If you have to treat those people at least 6 months, because when you withdraw steroids sooner than that, they inevitably relapse. And another condition in which that occurs is pericarditis. Mm-hmm. So when people have pericarditis, you have to maintain your treatment for a long time, because once the sensitivity is in place, whether it's humoral or some program into the lymphocytes, that will continue to recur even in the absence of antigen. Mm-hmm. So it's not just that the drug might be completely gone, but once that sensitivity has been created, it really needs a long time to stamp out.
Yeah.
And the other interesting thing is, as you're mentioning, and I've seen this a bunch now, is the reverse halo or atoll sign, whatever you want to call it, is clearly a sign indicating that the process is healing and resolving. But I still can't for the life of me figure out why this process cleans out from the center and not the periphery. You would think that lymphatic flow or drainage would be better along the periphery of an injury versus in the smack dab center of it. If anyone has any thoughts, I'd be interested to hear it. But
well, I wonder if it's just sort of like it's a time thing. It starts in the center and expands outwards, and the organization sort of, I always think of organizing pneumonia sort of as walling off whatever's going on, and then it starts clearing up in the middle because that's the more mature tissue, and then the macrophages or whatever start clearing the stuff out, sort of work their way out as the process matures. You'd almost need to, like, I don't know, scan these patients and lavage different areas to figure out what the cell types are. But it's just a time lapse, and it starts in the middle, it works, it expands out, so it clears the middle.
Yeah, it does. It's, they often start out as smaller lesions, like a nodule, that then kind of grows outwards and turns into the reverse halo or whatever. It's just an interesting process. Yeah. I've noticed a lot.
So I think the patients that we see that have the nice, pretty reversed halos are sort of, their symptoms have often been sort of,
they're subacute. They're kind of like, yeah.
All right.
Thanks, guys.
Yeah, thank you.
Thanks, everyone.
All right, talk to you later.
All right, see you next week. Bye.
Bye, everyone.